Okay. So, what do you think? What is the name of this technique? Okay. So, this is the procedure. Okay. So, what is the name of this technique? Because there are different techniques for doing this procedure, right? Home right. Yeah. Home way techniques. Home way technique. This is the one. Okay. So, what do we do? Yeah. So, what do we do during this procedure? Mm-hmm. Yeah. Okay. So, yeah, can it be done differently? Yes. Yeah. Mm-hmm. Yeah, assure. Yes. Yes, that's right. And mhm. Mm-hmm. Filshy clips, okay? That's what you want to say. Filshy clips you will apply. Filshy clips. Like this is the yeah. Then so the technique you have described in the right way, that it can be done under local anesthesia also. It can be done through various routes, laparoscopically, or what you can do, or you can do it through the posterior wall of the vagina, through the pouch of Douglas also, but usually it will be done laparoscopically. And we can tie the middle portion of the tube. We will hold the tube with a Babcock and cut it with the surgical scissors, myo scissors, and then ligate this one, double ligature. Or you can simply just insert Filshie clip, which is going to close the tube. So, and then you will tell the patient that the risk of failure is 1 in 200. What is the most common cause of failure? Because the tube has not been cut properly. Okay, so some area has remained behind, or sometimes this area will undergo yeah recanalization. Okay, it is 1 in 200, or some, because you will quote the figure from any study or any college which is more widely recognized. 1 in 200. Exact number it can be different, okay, but you should remember that 1 in 200 is the failure rate of the female sterilization. And what is the failure rate for the vasectomy? 1 in 2000, okay. So if they ask you to compare salpingectomy or this tubal occlusion with vasectomy, if you will say vasectomy is a better procedure because it can be done within 10 minutes as an office procedure, and after giving local anesthesia it can be done. But the couple will have to use another precaution for, like they can use this barrier method for next 3 months. Why? Because there will be enough number of sperms in the male ejaculate for 3 months, so they need to use another method also, otherwise there is a chance of pregnancy. So the failure rate 1 in 2000, and in females the rate of failure is very high. That's why it is better to do in the male. And then whenever you are doing this salpingectomy, you are doing this tubal ligation, you need to send this tissue for histopathological examination. Sometimes they will tell you that you did self-inject me on a patient during her third cesarean section. So it was done 6 months ago, and or they will tell you that it occurred 6 weeks ago, and the histopathology report shows that they have seen the right tube, but in the left tube sample they have seen only connective tissue. So the patient is very angry. What will you do now? Take 2 minutes and then we will talk about this patient. You did tubal ligation, but the histopathological examination confirmed that right tube is there, but in the sample of the left tube only connective tissue is found. So only connective tissue is found, no tubal tissue is found. It means that self-injectome not done on the left side. Now the patient is very angry. So how you will counsel her? You will take 2 minutes, then we will talk about this case. Yeah, you can start, please. Okay. Mm-hmm. Mm-hmm. Okay. Then don't worry. Because you know what she is telling you, histopathology report is one thing. You have to check, first of all, you did the right thing, okay? You asked her that when was her last menstrual period. To see that what is the chance that she is pregnant, okay? Then second thing is, you will tell her that we will do some investigations on that. I'm sorry that you have got this result, but before proceeding, we need to confirm the findings. How you will confirm that she has a blocked tube or she has an open tube? You will give her different options. Yeah, hysterosalpingography, but now the new recommendation is that don't offer hysterosalpingography. You should do saline infusion sonohysterography. You will do ultrasonography. You will introduce the fluid normal saline from down below, and then you will do the ultrasound at the same time. So then you will say that the tube is open or it is closed. So that is the thing, okay? So if the tube is open, then you will give her extra precaution, give her some additional method of contraception, and then you will offer her that either we can do pre-operation or we can give her some other form of contraception. And then you will write down a serious incident report, because if you intended to do some procedure and you couldn't do that, then you have to report on that, give that information and say that it can occur, but we will investigate that what has happened. If she will say that this is because of the fault of the doctor, you need to tell her that we cannot say anything, because sometimes surgical procedures can fail also, and maybe there was some infection, or maybe the tubes ends they reunited, okay? So that's why the lumen was open, so there is a possibility of pregnancy. And then you will counsel everything and you will say that if she says that I will like to complain, then you will tell her yes, you can see this manager and then you can register your complaint with them. And she will say that don't you think that that doctor is so bad and we should remove him, report against him? Then you should say that we cannot say anything, but we will follow the official procedure. So basically you have to show good ethics, don't say anything negative about any patient. Okay, that is the point. Okay, so let's go to the next one. You will take 2 minutes and then we will talk about it. Hello. Okay. So, what is this instrument? Yeah. So, what is the yeah, yeah, and why? What do we do with a colposcope? What is the indication for using a colposcope? Mm-hmm. Yeah, it is basically the for colposcopy to see the cervix. You can use the medical terms because it will be basically a case. It will be a viva, structured discussion. So they will ask you what is this. You will tell them that this is a colposcope. Why we use it? We use it to have a look at the cervix or colposcopy. So what are the indications for this procedure? Then you have answered this question. If pap smear was done, cervical screening was done, and there was some abnormality was noticed. Or the second indication is if there was some in lesion on the cervix and patient tested positive for high risk human papilloma virus, then we need to see the cervix to exclude any cervical pathology. So what type of stain is used? So patient has, yeah, yeah, and acetoacidic. So which area should be suspected of having any malignancy or any change? The white area or the pink area? The white area. And so aceto white area will be seen. So now we don't use this iodine test anymore, okay? Otherwise, they used to say that if the area is not taking iodine, then that is the dead area, but we don't do that anymore. We use this acetic acid. So aceto white area, you should see that. So what are the abnormal findings which can be seen on colposcopy? Now you will talk about the histopathology. Apparently, yeah, yeah, and yeah, yeah. You will see abnormal blood vessels, you will see punctate hemorrhages, and you can see plenty of cells, hypercellularity. Okay, so these are the features suggesting a malignancy. So, if abnormal cell they occupy the upper two-third of the cervical epithelium, what is the name? Okay, yeah, okay. So, if you will look at cervical dyskaryosis, what do you think? How do we classify that? Yes, there is. We will talk. Uh, Both are acceptable, but for the sake of this European board, better to follow this RCOG. Um, this is actually not RCOG, this is the FIGO guidelines, which are adopted by other European countries, and there is like a cervical screening program of the NHS, and same program is followed everywhere in the Europe. Okay, so we will talk about it in a while. Okay, look at this one. This is a cervical smear. Okay, So you are going to see plenty of cells. Okay, so you should say that if they ask you that how you will do this cervical screening, so as you know, we can do it in two different ways: conventional one, the pap smear, and the second one is liquid based cytology. Liquid based cytology is better because you can see the cells in a single line. Okay, so dyskaryosis means that this is a cytopathological diagnosis. It shows nuclear enlargement, variation in size and shape of the nuclei, and hyperchromasia. What is hyperchromasia? It will take a lot of pigments because many structures are there, and nucleus to cytoplasm ratio will increase. So then this karyosis can be mild, moderate, or it can be inadequate, it can be borderline, or it can be normal also. Mild cervical dyskaryosis or moderate or severe. So how do we say that which one is mild, which one is moderate or severe? Okay, this is the normal epithelium. Okay, here you don't see any changes. This is the low grade. Low grade means only lower one third of the epithelium has been involved. You are seeing many nuclei, right? And then they are closely packed cells. In the high grade, you can see that from base of the mid of this basement membrane to the upper two-third of the cells, they are involved. Here, see, small area. Here, a bit large area. Then in the third one, in the high grade, what happens in the low grade, lower part is involved. High grade, the middle is involved. It is going to the upper surface also. If there is a CIN, full-fledged cancer, then all of this area will be involved. So this is according to the Bethesda system. In the UK system, you will say that this is borderline. If there is only nuclear abnormality, then mild dyskaryosis if the changes are limited to lower one third. Moderate dyskaryosis if two-thirds of the epithelium is involved. Severe dyskaryosis if full thickness of the epithelium is involved. In the USA, the ACOG guideline, Bethesda system is used. So it can be low-grade squamous intraepithelial lesion, or it can be high-grade squamous intraepithelial lesion. So this will be the all of these are precancerous lesions. So if we talk about they will not ask you that how many people are having like mild dyskaryosis, how many will have moderate or severe. Okay. Then look at this one. This is CIN. Okay. On with naked eye, you will see only this structure. On colposcopy, you will see this one. Where when you will see in the higher magnification, you are going to see many blood vessels. So mild dyskaryosis, 5 to 10% of all cervical smears. Moderate dyskaryosis in just 1% of all smears. And the severe, the incidence is even lower, it is just 0.6%. So here in this question, they asked you that if you have like moderate dyskaryosis, what is your management? So what will you like to do for this patient? You need to take biopsy, right? Because for the confirmation of the cancer, you need that tissue for histopathological examination. So for you will do histopathology. So for that, you need the specimen. So you can do cone biopsy, or you can do this large loop excision of the transformation zone. So then you can proceed. So what is the disadvantage of these procedures? There can be bleeding from the cervix, and then if this patient becomes pregnant, there is a high chance that she will have a premature pre-labor rupture of membranes. These are the complications. Then there can be stenosis, there can be scarring, and there can be infection, there can be bleeding from the surgical site. So then you have to follow the guidelines. Usually when they bring a structured discussion, it will have 3 or 4 parts. So this is just one part. Maybe they will ask you other questions also. Okay. Yeah, yeah, okay. So we will talk about cervicals cytology, because basically we kept that one to cover in the oncology section, because that will be a pre-malignant lesion. So now there is another case for you. So you will take 2 minutes, then we will talk about her. Okay, you can start now. So how you will proceed? Yeah. So you will confirm her identity. You will ask about the investigations. And now she is here for the treatment of the uterine fibroid. So what you will do now? Yeah. Okay. Okay. Yeah. Okay. Yeah. Yeah. You will just tell her that you have mentioned many points. Actually, the problem is that yeah. Yes. Yeah. Yeah, but the point is that you consent will not be complete. That's why they will be asking you to complete that. That is the reason, okay? So the consent is there, but it is not complete, so they want you to do something. Because this patient was anemic and she has received how many units? She has received 2 units of blood. Yeah, yeah, that is the point. Yeah, that is the point. Okay, so you will confirm that she is not anemic anymore, and then we can proceed. So that is the point. So then, what will you tell her about the procedure? Everything we said in the start, that she will take antibiotics, she will need this, she will need that. Okay, all of these things. Okay, so what she should do now? Mm-hmm. Yeah. 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 Okay. Yes. You will document everything and then you will ask her that does she have any other question or not. So you will, yes, that is the point. Okay. So that's all. You will carry out any consultation, especially when you have to fill a form or anything. Okay. So for all procedures, even if usually they will ask you about the common procedures. So tomorrow when we will start, I want you to tell me about the steps of abdominal hysterectomy, steps of vaginal hysterectomy. Okay. These two procedures are important. And once we will start doing the obstetrics, then we will talk about the cesarean section. Okay. So these notes will be available. This recording will be available. So just go over the procedures and then antenatal care. So tomorrow, inshallah, same time we will talk. Is it okay? Yes, yes, that's what we will do. Okay, because yeah, sure. I will. Yesterday also I sent some notes. I will send again. Okay, and they will be on the web page also. Don't worry. Yeah, this one was not there because I wanted to ask you about the questions. Okay, that's why it was not there. But it will be available on the web page. Don't worry. Take care. So tomorrow 10 o'clock or 11 o'clock. Okay, no problem. Yeah, it's okay, inshallah. Don't worry, okay? Just study. See you tomorrow, inshallah. Take care. Bye bye. Bye.